Welcome to Chapter 27, Behavioral and Psychiatric Emergencies and Suicide. So, what is a behavioral emergency? First, behavior is any kind of manner in which a patient or person acts or performs. And then it becomes an emergency when that behavior within a given situation is unacceptable, intolerable to the patient's family, the patient, or community. Cultural behavior. Behavioral conditions require full patient assessment, and we want to remain objective. So, cultural behavior is those things that are acceptable within a given culture. So, you know, depending on, we may think it's not right, but within that culture it is. So, observable behavior is largely controlled by neurotransmitters inside the brain. These transmitters travel neuron to neuron, and the impulses move across um, nervous system by this mechanism. So the neurotransmitters, or lack thereof, have been implicated in depression and other behavioral and psychiatric disorders. Medications prescribed for these conditions are designed to affect the relevant neurotransmitters, and newer medications often offer reuptake inhibition of more than one neurotransmitter. Some behavioral emergencies are caused by psychiatric conditions or mental disorders. Almost 1 in 5 adults in the United States have some sort of mental illness. And mental health illness is declining or overcrowded. So more patients are with mental illness in the community are um, with minimal treatment, and this makes it more likely that we see those patients. It is getting a little bit better, but it's still there. Medical and traumatic conditions can also alter a patient's behavior, so hypoglycemia, hypoxia, strokes, head trauma, seizures, um, substances, and temperature extremes. Um, Situational stress reactions, so normal reactions to stressful situations produce emotions such as fear, grief, and anger. When caring for a patient with a situational stress reaction, do not rush them. Tell them that you're there to help. Remain calm. Keep your emotions under control. Listen to the patient and be honest. Okay, and as always, stay alert for um, changes in behavior. Acute psychosis, this involves a severe break in the patient's ability to process information and interact with their environments. It's often associated with some kind of psychiatric disorder, such as schizophrenia. Symptoms include hallucinations, delusions, catatonia, thought disorder, and they ensure that the safety of the patient and responders. So how do we care for these patients? They have a range of presentations. They may be withdrawn, not communicating, talkative, agitated, bizarre, or threatening behavior. They may have a wish to harm themselves or others. Key techniques is to identify yourself in your role, speak slowly and clearly, make eye contact, listen to the patient, and not be judgmental. Use positive body language, acknowledge the patient's feelings, do not enter the patient's personal space. You want to stay a distance away. Be alert for any kind of changes in emotional status, and use any kind of restraint to prevent harm if necessary. There's a couple courses out there that basically what you're doing is talking down the patient. There's a course out there called Verbal Judo, and it's getting the patient to do what you want them to do, but making it think that it's their idea. And that's really the um, the course that should be taught to any public service provider, police, fire, EMS. I mean, I believe everybody should take it. And basically, I mean, it's a great course, and it's just that verbal de-escalation. So when we assess these patients, you want to do a careful scene size up, make sure that you don't have any weapons or that there are no weapons available to the patient. Identify yourself and your role, complete your primary assessment, perform as much of the detailed exam as possible, and gather information through history. So common signs and symptoms include panic or anxiety, unusual appearance, disordered clothing, or poor hygiene. They may have agitated or unusual activity, unusual speech patterns, bizarre behavior or thought patterns, suicidal or self-destructive behavior, violence or aggressive behavior. Be alert for personal space and scene safety problems. Treat any kind of life-threatening problems. Consider medical or traumatic causes as well. Spend time talking to the patient. Encourage the patient to discuss feelings. Never play along with hallucinations, and consider involving family or friends. So I'm going to talk about a couple of these. Spending time to talk to the patient. So there are some situations where the first person that they see and meet, they automatically hate and do not want to talk to them. They're aggressive towards them, various other things. So make sure it's PD, so that way you can build a good rapport with that patient. Sometimes patients just don't like you, but they like your partner, which is fine. You can switch out people. Somebody who has a good rapport with that patient should be the one taking care of that patient. So if you can, switch out and just make sure that they're all good. And spend time talking to the patient, get on the patient's level. I have done many calls where I'd get on the floor and talk to the patient on the floor. Or they're in the closet. I don't necessarily go in the closet with them, but I, sit there outside the closet and I talk to the patient. You have to talk to your patient, otherwise you're not going to get them to do what you want them to do. And the next one I want to talk about is hallucinations. So this, to a point, you never want to play along with the hallucinations, but sometimes you just have to, because they need to go to the hospital, okay? They need to go to the ER, they need to get treatment for their mental health issue. So playing along to a certain degree of, okay, well, if there is this, then we need to go take you to the hospital and get you checked out, okay? So play along to a certain degree, but don't say, oh, I see it, type deal. Okay. 10th leading cause of death in the United States is suicide. Depression coupled with successful suicide has reached an alarming level in combat veterans and senior citizen populations. 22 veterans die a day because of PTSD and mental health issues, which is too many, in my opinion. Many more people suffer both physical and emotional injuries in unsuccessful suicide attempts. Anyone may become suicidal if emotional distress is severe, and people attempt suicide for a myriad of reasons. Potential or attempted suicide, we're going to explore the following possibilities with this patient. So depression, either at high levels of stress, either current or recent, any kind of recent uh, emotional trauma, maybe their age, 15 to 25 and 40, and drug and alcohol abuse. Um, these age ranges here are the higher suicide rates. Threats of suicide, whether or not they have a suicide plan, and previous attempts or threats, and then any kind of sudden improvement with depression. This sudden improvement, so if you notice that somebody is um, uh, depressed for months and months and months, and then all of a sudden they become happy and are absolutely okay with the world, then that means that they have a plan, and that this plan is to commit suicide. They're happy. They know what they want. They know for the first time in a long time what they want. So just be aware that if there is a sudden change, that they're planning suicide or could be planning suicide. So your first concern is your own safety. Then we're going to do a scene size up, identify and treat any kind of life-threatening problems, reassure the patient, perform a secondary assessment, detailed only if safe, and then reassess frequently and notify the receiving facility. Aggressive or hostile patients, consider clues, dispatch information, clues from the scene, information from neighbors, family, or bystanders, patient's stance or position in the room, ensure that there's an escape route, and do not threaten the patient, and just stay alert for any kind of weapons. It may not ever proceed beyond a primary assessment until the patient is calmed or restrained. Of course, you can look at your patient and determine whether or not they have an airway, whether or not they're breathing, and whether or not they have a pulse, and their general impression, or your general impression of the patient. So you can determine those things, kind of figure out what's going on. You may spend most of the time calming the patient and ensuring everyone's safety. Hostility or aggression is never an excuse for not assessing the patient as thoroughly as possible. Emergency care, so again, perform your scene size up, request additional help, seek advice from medical control if necessary, watch for sudden changes in behavior, and reassess frequently. And then also consider restraint. So reasonable force and restraint. Reasonable force is the force necessary to keep the patient from injuring themselves or others. Reasonable is determined by the patient's size and strength, type of behavior, mental status, and available methods of restraint. In most localities, restraint is within the jurisdiction of law enforcement. Never attempt restraint without proper legal authority and sufficient assistance. Excited delirium. I don't like this term, but mainly because it was a law enforcement term that turned into a medical term. But it is extremely agitated or psychiatric behavior or psychotic behavior. Triggers for it can include uncontrolled psychiatric illness or drug intoxication. These patients will frequently develop significant and even life-threatening cardiovascular and metabolic stress. Positional asphyxia is inadequate breathing or respiratory arrest caused by a body position that restricts the breathing. We're going to carefully monitor all restrained patients. Restraining a patient, you want adequate help. You're going to plan your actions. You're going to stay beyond the reach of the patient until prepared. Act quickly. As one EMT talks to the patient and calms them. Requires 4 persons, 1 at each limb. You're going to restrain all limbs with approved leather restraints in the supine position. Leather or soft restraints. So we are responsible for the restrained patient's airway, ensure that the patient is adequately secured throughout transport, apply a surgical mask. For spitting patients, we have spit hoods that we regularly put on. Well, I say regularly. I haven't put one on since we got them. So reassess frequently and document thoroughly. Transport to an appropriate facility. So not all hospitals are prepared to treat behavioral emergencies. You're going to choose the correct facility based on capabilities and local protocol. Most hospitals can treat behavioral emergencies. Now, whether or not they keep that. Medical and legal considerations, so sexual misconduct. Behavioral patients sometimes accuse EMS providers of sexual misconduct. I have been accused of sexual misconduct. Yeah. So if possible, have a same-sex provider attend to the patient. And for aggressive or violent patients, make sure that law enforcement officers accompany you to the hospital, just to protect you and the patient. And in the event of a legal problem, they can serve as a third-party witness. And when I worked at the BLS truck in Springfield, I had a couple different patients that would like to masturbate, both female and male. When the female started doing it, I had a female partner, and even though it was a female patient, it didn't really matter because we basically switched on and off. So if it was hers and it was a male patient, she would take it. If it was mine and my turn and it was a female patient, I would take it. It didn't really matter, except in this instance where the female patient started masturbating, and we had issues. I hollered up at my partner, said, "Hey, we need to switch," and she switched, so that way she could be in the back with the patient, and there was nothing, no hanky-panky gonna go on. So
Combative patient or attacker? I'm here to tell you there's no such thing as a combative patient. I'm Kip Teesort, and that's what we're going to talk about in this episode of Escaping Violent Encounters. Universally across the country, something that I've found in every station that I've been to is that there is a distinct confusion between what is and what is not a patient. I will tell you that one of the things that we describe is there is no such thing as a combative patient. They simply just cannot exist. Think about it like this. What a person says and what they do equals your reasonable belief as to whether they are or they are not a patient. How many times have you been on a scene with a person who's drunk or drugged who becomes aggressive? There are laws against that. That's a crime. Versus the person who may be confused due to hypoglycemia, hypoxia, sepsis. That would be somebody who is an uncooperative patient. The danger of us keeping this phrase of combative patient is that because we care for patients, our staff will remain connected with people that they shouldn't, meaning that it is so dangerous for them that they want to constantly remain in contact, too close, continue talking when they should be putting their hands up, backing away, and giving them the understanding that this is not part of my job. That's why we don't receive the training for controlling people, because that's just not our job. There is a distinct difference between a patient and an attacker. The moment we get this understanding throughout EMS, the moment we can begin reducing assaults in medicine pretty much overnight. An example of a patient would be somebody like a diabetic in a hypoglycemic state, where as you attempt to establish an IV, they may pull away from you. This is uncooperativeness. This isn't aggression. Another example would be a TBI, a traumatic brain injury, someone that had been in a car accident, someone who's hypovolemic. Again, as you attempt to start an IV, maybe they grab because they're scared, they're confused, they don't know who you are. Contrast that with a person who is high or drunk, who should actually be in custody. This is that person in the back of the ambulance or on scene begins to give you verbal threats. They tell you what they're going to do to you. They tell you what they're going to do to your family or your partner. And then they begin to reach out aggressively, remove the straps aggressively. These people can sometimes become very dangerous for us, specifically when it becomes a desperate type situation, meaning they want to get away and you're in their way. And every time we place ourselves in a position to try to stop them, that's the moment our providers are being criminally assaulted. And again, now let's contrast that back. We have had providers criminally assaulting real patients because they call them a combative patient, and we immediately relate that to fighting. So again, the moment you recognize the difference between an uncooperative patient who we're supposed to stay and play and treat versus an aggressive attacker who's giving you verbal threats and physical actions, who's attempting to cause harm to you criminally, those are two completely different people. You get that, and you will instantly be safer on the job. So across the country, the biggest problem that I've found from coast to coast, whether it be in a fire department, whether it be at the EMS base, is this distinct confusion between what is a patient and what is an aggressor. The moment you understand that there is no such thing as a combative patient, we can immediately keep you safer on the job. I'm Kip Teesort, and remember, your safety comes first.
So if you have questions, let me know, and we will get those. I'll get those answered to you as soon as possible.